Well, good morning, good afternoon, good evening to all of you, and welcome to this Anesthesia and Analgesia webinar on quality and safety in obstetric anesthesia. This accompanies the themed issue that was published in December of 2025. I am the moderator and host. I'm also the section editor for obstetric anesthesia. My name is Jill Mhyre, and I am at the University of Arkansas in Little Rock, Arkansas in the USA. And it is 12 o'clock here. I am so excited to present three groups of authors who have submitted articles that we are featuring from the themed issue. The first is Dr. Marie-Pierre Bonnet. She is a French anesthesiologist who works in the Mother and Child Armand Trousseau Hospital in Sorbonne, France. And she's been obstetric anesthesia and intensivist specialist for more than 10 years. She's also an associate researcher in the EPOPE team from the Center for Epidemiology and Statistics in Sorbonne in Paris. Her partner in crime is Dr. Catherine Deneux-Tharaux, who is a research professor also at INSERM in the Sorbonne in Paris. And they will have a recorded presentation discussing their submission, Trends in Maternal Mortality from Obstetric Hemorrhage in France, which is a summary of the lessons learned from 15 years of their confidential inquiry. We also have Dr. Oscar van den Bosch. He is a staff anesthesiologist from the Netherlands, specializing in obstetric and pediatric anesthesia. He completed training at University of Toronto and is currently the lead obstetric and pediatric anesthesiologist at the Wilhelma Children's Hospital, University Medical Center in Utrecht in the Netherlands. And I believe for all of you, it's about 8 o'clock in the 7 o'clock in the evening. And then our last presenter pair is Dr. Engela Kuün. She is an anesthesiologist based in Pretoria, South Africa. She works in private practice and serves as a public session consultant at Steve Biko Academic Hospital and the University of Pretoria. She's here with Professor Sandra Spiekerman, and they will be discussing a curriculum development for the South African essential steps in managing obstetric emergencies for the anesthesia training module. And I believe it's 8 o'clock in Pretoria. So welcome and thank you, all of you, for joining us today. And I believe the next item on the order of business is to start the recorded presentations.
Hello, everyone. Today, we are very grateful to Anesthesia Analgesia for giving us the opportunity to present the results of our study on maternal mortality from obstetric hemorrhage in France, 15 years of confidential inquiry into maternal death. I'm Catherine Deneux-Tharaux, and I'm leading the French National Confidential Inquiry into Maternal Death. I have no financial relationships with commercial interest to disclose, and my presentation does not include discussion of off-label or investigational use.
I am Marie-Pierre Bonnet. I have financial relationship with 2 different companies, and my presentation does not include discussion of off-label or investigational use.
Within overall maternal mortality due to obstetric hemorrhage is one of the main causes and is considered as a specific marker of the quality of obstetric care. In France, enhanced surveillance of maternal mortality has started 20 years ago through a permanent system that we will describe later, the Confidential Inquiry into Maternal Death, called in French Enquête nationale sur les morts maternelles, ENCMM. The first publication of this inquiry reporting an alarming profile of maternal mortality from obstetric hemorrhage. Obstetric hemorrhage appeared as the primary cause of maternal mortality, which is a profile you do not expect in a high-income country. The maternal mortality ratio due to obstetric hemorrhage was twice that of neighboring high-income countries, in particular the UK and the Netherlands, and almost all deaths due to obstetric hemorrhage were considered preventable, with preventability factors that paved the way for improvement activities. These findings led to a broad commitment of all stakeholders to improve obstetric hemorrhage-related management. The French College of OBGYN, together with the French Society of Anesthesia and Critical Care, developed and launched the first multidisciplinary national guidelines in 2004. Ground clinical teams worked on local implementation of these guidelines. Governmental Agency for Quality of Care implemented quality indicators on obstetric hemorrhage care in maternity units. Finally, research was developed to document the obstetric hemorrhage epidemiological profile and to assess the components of care that were inappropriate. A positive impact of this measure could be expected as part of this general mobilization. However, their effectiveness in reducing mortality had not yet been evaluated on a national scale. That is why our objective in this study were to assess the temporal trends in incidence and underlying causes of maternal death from obstetric hemorrhage in France from 2001 to 2015, and to describe clinical care provided to women who died from obstetric hemorrhage before the 2001 to 2003 period and after the 2013 to 2015 period implementation of the first national guidelines. We conducted a retrospective study of all maternal deaths due to obstetric hemorrhage in France between 2001 and 2015, identified through the French National Confidential Inquiry into Maternal Deaths. Since 1996, this permanent survey system has studied all pregnancy-associated deaths in France in a three-step organization. Deaths are first identified through linkage of various databases or directly reported by clinicians. Then for each identified pregnancy-associated death, a team of assessors, combining an obstetrician or midwife and an anesthesiologist, conducts an on-site confidential inquiry using a standardized questionnaire to collect all relevant information about the case through interviews and review of all medical records. Finally, although this information is anonymously reviewed by the National Expert Committee and classified with regard to the underlying cause of death and the relation of death with pregnancy. Preventability is then assessed and refers to any event in management, organization, or patient behavior that might have prevented the fatal outcome. Here are the results of our study. We found that over the 15-year study period, the proportion of deaths due to obstetric hemorrhage considerably decreased from about 1/4 to 10% among all maternal deaths. The MMR from obstetric hemorrhage fell by more than half from 2.3 to 0.8 in the most recent period. And this decrease was particularly marked, as you can see here, for deaths from hemorrhage due to uterine atony. The decrease in hemorrhage-related deaths was the main driver for the overall decrease in maternal mortality observed over this period. Further exploring the profile of maternal deaths due to obstetric hemorrhage, we found that over the study period, the proportion of uterine atony as the primary underlying cause of obstetric hemorrhage decreased from 50% to 21% in the last period, while the proportion of death due to cesarean surgical trauma increased from 2% to 21% during the same time period. Over the same period, the preventability of death, as assessed by the expert committee, remained very high during the whole study period, over 85% of the women in each triennium.
This table reports critical care management in maternal death from obstetric hemorrhage separately in 2001 to 2003 and in 2013 to 2015. We can note that overall, in the second time period, critical care interventions were applied earlier and more adequately than during the first time period. For example, hemodynamic continuous monitoring with invasive arterial blood pressure increased from 30% to 47%, and the use of vasopressors increased from 57% at baseline to 72% in the last time period. Finally, while at baseline 5 women were extubated during active bleeding, this did not happen anymore in the most recent periods. Transfusion therapy was also applied earlier and more frequently with time. The proportion of women transfused with red blood cells, fresh frozen plasma, and platelets, and the total number of blood products transfused increased with time, and delay before start of transfusion was reduced by 1/3 between the two time periods. The use of fibrinogen concentrate doubled, and tranexamic acid and recombinant factor 7A that were never used during the first study period were administered in more than 40% of the women in the last time period. This figure reports transfusion of red blood cells, fresh frozen plasma, and FFP to RBC ratio according to time during the first 24 hours after the diagnosis of hemorrhage. You can notice that during the course of obstetric hemorrhage, the FFP to RBC ratio remained constantly superior to 0.6 in the most recent time period and not during the first time period. Finally, clear improvements were also observed in the obstetric management of obstetric hemorrhage due to uterine atony. Indeed, 100% of the women who died from uterine atony received second-line uterotonics as compared with 67% in the first time period, with a decreased time between the diagnosis and administration of second-line uterotonics. Also, 100% of the women who had an uterine atony had a hysterectomy in the second time period as compared with 75% in the former period. Among the women who died from all cause of obstetric hemorrhage, still around 30% of the women died without an hysterectomy in both time periods. All the 6 women who died without hysterectomy in this last time period gave birth by emergency C-section. In 3 of these 6 women, the obstetrician did not have the surgical skills to perform hemostatic surgery. The main preventability factor in the most recent period were related to 2 specific aspects. First, a delay in intra-abdominal bleeding diagnosis after C-section with a late detection of abnormal vital parameters due to suboptimal postpartum surveillance, notably in the recovery ward, and too late or no performance of bedside ultrasound to detect intra-abdominal bleeding. The second preventability factor were related to a delay in hemorrhagic management with an underestimation of the severity of bleeding and also to insufficient surgical skills to perform hemostatic surgery. To sum it up, over 15 years, we observed that maternal mortality due to obstetric hemorrhage in France has significantly decreased by 2/3. Over time, less women died from uterine atony, and concomitantly, critical care, transfusion management, and obstetric management for uterine atony improved with time among these women who died from obstetric hemorrhage. However, in the most recent period, the large majority of obstetric hemorrhage maternal deaths remain preventable, with maternal mortality ratios still higher in France than in other high-income countries, as reported in Digisto et al. In 2023. Also, the contribution of maternal deaths due to caesarean surgical trauma increased, with emerging areas for improvement concerning first the diagnosis and the management of hemorrhage in the context of caesarean birth, and also concerning the skills of surgical procedure for obstetric hemorrhage. Thank you for your attention.
While we're loading the next video, I forgot to say, but would want to let you know that you can enter questions in the Q&A on the Zoom bar.
Hello, everyone. Thank you very much for inviting me to this webinar on the quality and safety of obstetric anesthesia, which I think is a very interesting and a very important topic as well. And I will discuss our recent paper titled High-Axial Block in Obstetrics, a 2.5-year nationwide surveillance approach in the Netherlands. My name is Oscar van den Bosch. I'm an obstetric and pediatric anesthesiologist at the Wilhelmina Children's Hospital. The Wilhelmina Children's Hospital is a dedicated pediatric and obstetric hospital in the beautiful city of Utrecht, the Netherlands. It's part of the University Medical Center Utrecht, and we do approximately 3,000 deliveries per year, mostly third-line referrals and high-risk deliveries. I have no conflicts of interest to declare. So, what are we going to discuss? First, I will show you some background information and I will show you the objectives of our study. I will describe the methods that we used, talk a bit more about the surveillance-based approach that we had. I will show you the results, and I will afterwards give you some interpretation of the data and conclusions that we may draw. So let's talk about high-axial block. What do we know about it? Well, first of all, we know that high-axial block is the most frequent serious complication of obstetric anesthesia. This is some US-based data from the Society of Obstetric Anesthesia and Perinatology, SOAP. And after 5 years of data collection, they found that high-axial block was actually quite common, even if you compare it to other serious complications, such as respiratory arrest, epidural abscesses, and cardiac arrest, with high-axial block occurring in almost 1 in 4,000 deliveries. And high-axial block is characterized by excessive cephalad spread of local anesthetics through the intrathecal or the epidural route, and it leads to, well, firstly, tingling fingers. It can lead to shortness of breath. It can lead to respiratory insufficiency, apnea, and ultimately cardiac arrest. So this is a very serious complication that we need to monitor. And the reported incidences of high-axial block vary greatly. If we look at a study by Jenkins and colleagues in a specific region in the United Kingdom, Southwest Thames, they have an incidence of 1 in almost 16,000. A study by Scott and colleagues across the whole United Kingdom showed almost 1 in 4,000, and the United States data is quite similar. And we hypothesized that the incidence of high-axial block is probably affected by two things. One, the methodology used to investigate high-axial block, but also by the healthcare system itself. So most of you will know the Netherlands as a small country in Europe, known for its windmills and bicycle use. But not a lot of you will know that our obstetric healthcare system is quite different from other developed countries. So 13.1% of all deliveries are done at home by primary care midwives. Less than 1 in 4 women end up having or wanting epidural analgesia in labor. Our cesarean delivery rate is quite low, it's 18.1%. But most importantly, the anesthesiologists are not routinely present in the labor and delivery room. Instead, we work in the operating rooms and we have to go to the labor and delivery ward, place an epidural catheter, and delegate further management to other healthcare staff. And we think that this may impact the incidence and features of complications in obstetric anesthesia in our healthcare system. So we used the Netherlands Obstetric Surveillance System, NETHOS, which is part of the national audit, and its goal is to analyze severe maternal morbidity, mortality, and rare diseases. And previous work was done on eclampsia, uterine rupture, maternal cardiac arrest, coronavirus disease, and recently spontaneous hemoperitoneum in pregnancy. And what we did with this surveillance system is that we sent monthly emails to every reporting physician. And they are located in every maternity hospital in the Netherlands. So every hospital that does obstetrics gets these emails on a monthly basis to report cases. And during this study, we asked them to report cases of high-axial block requiring tracheal intubation, laryngeal mask area insertion, or cardiopulmonary resuscitation. So that was our definition of a high-neuraxial block. If they reported a case, then we requested to receive the clinical data, and we did a confidential analysis of the clinical course and the anesthetic management of the high-neuraxial block. So these are our results. We did data collection during 2.5 years. There were 7 reported cases in that time period. One of them was a woman who needed oxygen by face mask. One of them was a woman who needed brief bag mask ventilation. And these 2 cases were excluded as they didn't meet inclusion criteria. And this meant that we ended up with 5 confirmed cases of a high-neuraxial block requiring tracheal intubation in obstetrics. If we link that to the total number of births and the total number of births with a neuraxial procedure from the National Birth Registry, then we found that the incidence of high-neuraxial block in neuraxial obstetric anesthesia was 1 in 29,770. So let's look at those cases. If we categorize them, then we start with 5 confirmed cases of high-neuraxial block, and 4 of them were women who intended to have a vaginal delivery with epidural analgesia. 3 of those ended up having an interpartum cesarean delivery due to failure to progress in the first stage of labor. And they all had a spinal anesthetic in the operating room. So their epidural wasn't used to give epidural anesthesia for cesarean delivery, but instead the epidural catheter was pulled and they received a spinal anesthetic. And these 3 cases had high-neuraxial block. The 4th case of an intended vaginal delivery received a test dose through the epidural catheter and developed a high-neuraxial block on that. And the 5th case was a planned cesarean delivery for breech presentation, and she received a single-shot spinal followed by a high-neuraxial block. So let's look at the case details. These are the first 3 cases, BMIs of 23 and 29. And they all had single-shot spinals for cesarean delivery after labor epidural analgesia. The hospitals where these occurred, they provide epidural analgesia with a low concentration of bupivacaine, with added fentanyl as the opioid of choice. And they run continuous infusions of 10 or 8 mLs per hour. The first woman had 2 4 ml boluses of that solution during labor, and the last bolus was more than 2 hours before the spinal anesthetic, and the other 2 didn't receive any boluses during their labor. They went to the operating room for a cesarean delivery, and they received a spinal anesthetic. Case 2 and 3 received hyperbaric bupivacaine, 10 and 12.5 milligrams, and the first one received articaine, which I'm sure not many of you will be familiar with, but it provides a good intrathecal block for about an hour. Which may be sufficient depending on your obstetric practice. They all occurred in the operating room. They were intubated quite quickly after the intrathecal injection and extubated after the cesarean delivery in the operating room without the need for intensive care admission. The 4th case was a woman with a BMI of 26 who received a labor epidural, and she was administered 40 milligrams of lidocaine through the epidural catheter as a test bolus, which quite quickly led to the feeling of dyspnea, which led to a pronounced motor block and also difficulty to breathe, and she was then transferred to the operating room and given general anesthesia with tracheal intubation there, and she also underwent emergency cesarean delivery. She was also extubated briefly after her delivery. The 5th case received a spinal anesthetic for an elective or a planned cesarean delivery. She received 14 milligrams of hyperbaric bupivacaine, leading to respiratory insufficiency within 10 minutes of the intrathecal injection. And she was swiftly intubated. So all patients were extubated in the operating room. Interestingly, 2 out of 5 cases, 2 out of 5 women, and they indicated that this was very traumatic to them, and they received psychological support throughout quite long into the postpartum period to address ongoing anxiety and the development of post-traumatic stress disorder. If we look at the neonatal outcomes, they were quite favorable. And they had good APGAR scores after 5 to 10 minutes, and there were no neonatal deaths. So let's place this into perspective. Well, I think we learned that hyonoraxial block is rare but very impactful, and direct intervention by the attending anesthesiologist prevented further harm to either mother or child. We found no cases of cardiac arrest due to hyonoraxial block, which was quite surprising because previous data from the United Kingdom showed that 22% of cardiac arrests were associated with neuraxial anesthesia. Reassuringly, a similar study from the Netherlands showed that 3% of cardiac arrests were anesthesia related. If we look at the anesthetic management of a cesarean delivery in a patient with an epidural catheter in situ, then we know that a spinal anesthetic after a failed top-up is a known risk factor for hyonoraxial block. But previous studies seem to indicate that spinal anesthetics without a recent top-up may be safe. We report 3 cases of hyonoraxial block associated with spinal anesthesia after prolonged epidural analgesia without recent top-up, which is quite interesting. And we all know that a well-functioning epidural catheter may be used to facilitate an intrapartum cesarean delivery. But it's important to highlight that this requires routine and regular assessments of labor epidural analgesia quality. And if you're not physically present in the labor and delivery room during maintenance of analgesia, this is quite hard to arrange. So we need to have a system where we delegate these routine and regular assessments to other healthcare professionals if we want to use this epidural catheter for surgical procedures, and that's not easy. So compared to US and UK data, United States and United Kingdom data, we only identified a low number of hyonoraxial blocks. And I think there are 2 things to consider. First of all, obesity is a known risk factor for hyonoraxial block, and our obesity rate is very low compared to other developed countries. It's between 10 and 20% at the moment. And second of all, there may be differences in the anesthetic management in obstetrics between countries. And these may impact the risk of high block, but also the quality of anesthesia and labor analgesia. And more studies are needed to see if our low hyonoraxial block rate may be due to differences in anesthetic management. And this is something an ongoing study will address further. And we are recruiting patients in more than 30 countries across Europe at the moment to see what these differences are in the management of cesarean deliveries. The strengths of our study is that we use the Netherlands Obstetric Surveillance System, which is a well-established prospective population-based system, and that all Dutch obstetric units participated. The limitations, well, firstly, potentially not all cases of high block were noted by the reporting obstetricians, even though I think this is a very impactful and very memorable event. This study was done partly during the coronavirus pandemic, and cases of borderline respiratory insufficiency may have been handled differently in non-pandemic times. And lastly, of course, we were limited to the information provided by the reporting physicians. So what can we conclude? I think these are the 4 most important conclusions. We conclude that the incidence of hierarchical block in obstetrics was very low, up to 1 in 12,758 deliveries. We also conclude that a hierarchical block occurred predominantly following spinal anesthesia after prolonged epidural analgesia with or without recent top-up. And also very important is that direct intervention prevented further harm, but also that adequate psychological support is warranted for this very stressful experience at a very important time point in the life of a young woman. And our last conclusion is that it's clear to us that nationwide audits are needed to monitor adverse events in anesthesia in general, but obstetric anesthesia in particular, because we need to evaluate the quality of care, and they may differ in different healthcare settings. Thank you very much for your attention.
Good day, my name is Engela Kuün and I am presenting my Masters of Medicine dissertation in the Department of Anesthesiology at the University of Pretoria, South Africa. The title of my research is Curriculum Development for the Essential Steps in Managing Obstetric Emergencies, ESMO-E Anesthesiology Training Program, a Delphi study. My supervisor was Prof. Sandra Spijkerman. I have no financial relationship with commercial interest to disclose, and my presentation does not include discussion of off-label or investigational use. Every woman, every newborn, everywhere has the right to good quality care is the message from the 2016 Lancet Maternal Health Series. Improving quality of maternal health and reducing maternal mortality has been a global goal for the past quarter century, as females play a critical role in human progress and the development of socioeconomics. Maternal mortality has been a global healthcare priority for the past 25 years. The UN Sustainable Development Goal 3 aims to reduce maternal deaths to fewer than 70 per 100,000 live births by 2030. However, South Africa is far from achieving this target, with an in-facility maternal mortality ratio of 113 per 100,000 live births for the period 2017 to 2019. A notable concern is the role of anesthesia in these deaths. Of all maternal deaths, 2.39% are attributed to anesthesia. What's alarming is that 93% of these anesthetic-related deaths were deemed preventable. South Africa's public healthcare sector faces a severe shortage of specialist anesthesiologists. Only 0.5 anesthesiologists per 100,000 people compared to the recommended 5. As a result, anesthesia in district hospitals and regional hospitals is often performed by junior doctors without specialized training. This gap contributes to preventable maternal deaths caused by complications like hypertension, aspiration, and failed intubation, worsened by inadequate internship training. To address these issues, several training programs have been implemented. One of the main initiatives is the Essential Steps in Managing Obstetric Emergencies, ESMO-E Training Program, which was introduced in 2008. This program includes a module of obstetric anesthesia. However, its impact has been limited due to the inconsistent implementation and outdated content. Another initiative, the Safe Obstetric course, focus on upskilling medical officers. But again, the challenge lies in reaching all the healthcare providers who need training. The objective of this study was to gather input from South African anesthesiology experts on the current ESMO-E anesthetic training module We aim to assess its appropriateness and identify areas for improvement. The results will guide the revision of the ESMO-E module, ensuring it aligns with the current needs and standards. The study conducted from March to August 2021 used a mixed method approach with a 3-round modified Delphi technique to gather expert input from the South African anesthesiologists. The flow diagram showing the participation of experts during the 3-round modified Delphi study. Phase 1. The research team created the Round 1 Modified Delphi questionnaire based on the current ESMO-E anesthetic training program in an online Likert scale questionnaire with open-ended comments. 6 anesthesiology specialists from the University of Pretoria validated this questionnaire. Participants were identified by the head of anesthesiology departments at all South African medical schools, focusing on those with obstetric expertise in the public sector, as this is where internship training and community service training occurs. Private sector specialists were excluded due to the differences in resources. 30 participants were invited and 24 agreed to participate. Phase 2, RedCap, a secure data platform, was used to distribute the questionnaires and capture the responses. Weekly email reminders helped ensure timely participation in each of the 3 rounds. Round 1, the questionnaire was distributed to the 24 participants. 17 participants completed the questionnaire. Analysis for consensus were done. A feedback report and a Round 2 questionnaire were compiled. The Round 2 questionnaire consisted of the non-consensus statements of Round 1, as well as new questions that were generated from the participants' comments. Phase 3. The Round 2 questionnaire was distributed to the 17 participants of Round 1. 16 participants completed this questionnaire. Analysis for consensus were done, and the feedback report and the Round 3 questionnaire were compiled. In Phase 4, the Round 3 questionnaire was distributed to the 16 participants of Round 2. 15 participants completed this questionnaire. Analysis for consensus were done, and the final reporting were done. As said, a total of 24 experts participated in the study, all with at least 5-year anesthetic experience. The majority, 65%, worked in tertiary or central public hospitals, and participants represented 6 of the South African 8 medical schools, ensuring diverse expertise and a wide geographical spread. Across the 3 Delphi rounds, participants reviewed 52 statements. Consensus, defined as at least 70% agreement among participants, was achieved for 39 of 43 statements in Round 1, 6 of 9 statements in Round 2, and 3 of 5 statements in Round 3. However, 2 statements did not reach consensus across all 3 rounds, highlighting ongoing areas of disagreement that may require further consideration. 75% of experts believe that the current ESMO-E program is inadequate for preparing interns to manage obstetric anesthetic emergencies. 94% recommended updating it to a blended learning format, combining online and face-to-face training to standardize content, reduce teacher workload, and improve accessibility. The challenges, though, includes the high setup cost and the potential internet issues. All experts agree that the program should be mandatory for interns, funded by the Department of Health due to its potential to improve maternal health outcomes. They also emphasized retaining all the current program objectives, including pre-anesthetic checklists, spinal and general anesthesia protocols, and airway management and blood loss estimate training. In light of the Saving Mothers report and major anesthetic-related causes of maternal mortality, experts recommended the following should be included in an ESMO-E anesthetic training program: maternal anatomical and physiological changes, pre-anesthetic checklist, difficult airway equipment, fasting period guidelines, aspiration prophylaxis guidelines, hypertensive disorders in pregnancy anesthetic management, placenta previa anesthesia, and upper rupture placenta anesthesia management. Contraindications to spinal anesthesia list, local anesthetic maximal dosages, potential complications of spinal anesthesia management, and this includes hypertension and high spinal, anticipated difficult airway management, unanticipated difficult airway management, difficult airway society guidelines for obstetrics, surgical cricothyroidotomy, aspiration management, anaphylaxis management, maternal cardiac arrest algorithm, perimortem cesarean section delivery, neonatal resuscitation, and an ethics component. While most areas achieved consensus, some statements remained unresolved. Needle cricothyroidotomy was excluded due to the high failure rate, also seen in NAP4, with surgical cricothyroidotomy preferred as a safer option. Disagreement also arose around local anesthetic systemic toxicity lost. Some experts deemed it rare and non-critical, while others highlighted its relevance to the drug error risk in obstetric anesthesia. This slide provides an overview of the study's strengths and limitations. The strengths: nationwide experts' inclusion ensured diverse opinions. The Delphi technique captured consensus and insight, and literature-based suggestions enhanced the program. The limitations, though: it was limited to tertiary hospital experts. Intern opinions were not included, and we focused on broad outcomes and not specific objectives. To conclude, the revised ESMO-E program with compulsory blended learning will ensure consistent and accessibility of training for all interns. Developing a national obstetric anesthetic guideline will align training across undergraduate, internship, and post-internship phases, addressing the current inconsistencies. Collaboration among the key stakeholders, including the Health Professional Council of South Africa, the National Department of Health, the Society of Anesthesia, and academic institutions, is essential to drive the transformation. Prioritizing funding and leveraging public-private partnerships will support implementation and sustainability. A standardized, effective training framework will enhance intern competency, reduce maternal mortality, and improve obstetric anesthesia care across South Africa. You can review the article for my references. Thank you.
Well, now, if everybody wants to turn their cameras back on, we have a whole list of questions, and I, of course, brought some as well. And I thought we could talk about the papers in turn, focusing on hemorrhage and then high block, and then training systems for rare emergencies and how we can make that more feasible. So I guess the first question is for Doctors Deneux-Tharaux and Bonnet. Really, kudos to all of the French anesthesiologists who've been implementing these protocols over the last couple of decades. The improvement in uterotonic administration from 30 minutes to 9 minutes is such an accomplishment in itself, and you've demonstrated that it actually probably saved some lives. So that's really outstanding result. I noticed that 57% and then 59% of the women who died were born abroad. And I'm curious if there was much conversation about vulnerable populations and how we should be thinking differently about approaching their care.
Maybe I can answer that, Marie-Pierre. Is that okay with you?
Yes.
Yeah, thank you very much for this question. Actually, we are also very alarmed by this finding, because it's true for hemorrhage-related death, but it's true overall for maternal deaths, and actually migrant women in France who are responsible for about 1/4 of all births in France. So it's a very large group, have very worse outcomes, and in particular, one subgroup of women born in sub-Saharan Africa have a three times higher mortality ratio. So we've conducted some previous works that showed that even if you take into consideration their comorbidities and other risk factors, you still have a very high difference. And some elements in our analysis showed that the quality of care provided to these women was more often inappropriate. And there is a bunch of research who has started about implicit bias that could be implied in the way you provide care to some vulnerable women, in particular in France, migrant women. So that might be an explanation.
And I sit on the mortality review in Arkansas in the United States, and these are common themes around the world. I'm curious about language, and I think sometimes when folks speak different languages, it can be difficult to communicate. They may not be able to relay their symptoms. And then also, particularly with concealed hemorrhage, which was kind of the new story that you described at the end of the surveillance period, it can be easy to dismiss women who will say that they don't feel well, and really they do need that aggressive investigation. We had several of our audience members ask about ultrasound and ultrasound procedures to evaluate for concealed hemorrhage or to evaluate for that uterine stripe. Who does it? What are the skill sets? How are you training your anesthesiologists in France?
Yes, thank you for this question. Indeed, in France, anesthesiologists as well as obstetricians are formed to perform abdominal ultrasound for the diagnosis of hemoperitoneum. So it can be performed by either the anesthesiologist or the obstetrician, because in particular, residents in anesthesiology are also able to take care of trauma patients. So they can do fast ultrasound of the whole body. And for example, for the women who are monitoring in the post-operative room, it could be either the obstetrician or the anesthesiologist who do the diagnosis of hemoperitoneum by ultrasound. So I don't know if it's different in other country, but in France, it's really a multidisciplinary management for this diagnosis.
Yeah, that's interesting. And for us as well, we might look at we might do the cardiac ultrasound and see how full the heart is at the IVC. The obstetricians will look for the uterine stripe and maybe do the FAST exam. And my experience, though, is that oftentimes if she's stable enough, we end up going for CT to really see what might be going on in the retroperitoneal space. And that tends to be where the blood is hiding.
Mm-hmm.
Sure. But the advantage with the ultrasound is that you don't have to move the patient. And sometimes when they are not really stable, you cannot, for example, in my hospital, the CT is not very close to the operative room, so it could be a difficulty to perform such exam, and it's easier to limit us on the ultrasound. But sometimes you don't have the diagnosis by ultrasound, but still you have an hemoperitoneum, so you have to repeat the exam too.
Yeah, it's my experience that we can see with the TTE that we can see the heart is empty. But if the blood is collecting in the retroperitoneal space, we may not see it with ultrasound. And so we just have to advocate for our patients. And if they're really unstable, we push to go back to OR to open and see what's going on.
Yes, sure.
Yeah.
Yeah.
Okay, somebody is asking how ideas on how to approach IV access for labor and delivery and how we standardize it, and if you saw any heterogeneity in venous access in your review of these deaths.
Yes, maybe it's another particularity of France, because all women who are admitted in the labor ward has an IV access, especially if it's always combined with an epidural analgesia. And as you know, we have a very high rate of epidural analgesia, more than 80%. So all the women who has a traditional delivery, vaginal delivery, as an IV access, and of course all the women who had a C-section. There is only one particularity for the woman who wants to have a more physiologic delivery, but still we put only the access. We don't use crystalloid infusion, but for all the other, we have all the women has an IV access for safety reason. So at least one. And in the French guideline on postpartum hemorrhage, it is clearly mentioned that you have to put a second IV access and even central line when the woman starts bleeding. And usually we put the second IV access when we perform the first biological tests.
Yes, same with us. So we'll put the IV in, draw some labs, and send them off. We get viscoelastic testing. I saw that was unusual in your study. I'm curious. The study ended in 2015, so maybe things have changed since then.
Exactly. That's one an important point. Good question for. And it will be interesting to see because. Of course, in 2015, there was only few university centers that were equipped with viscoelastic tests. And at that time, it was still just for the experience, just to start with these devices. But now I suppose it could be the same in your center, but it's much more democratized, the use of viscoelastic device. And for example, in all the institutions where I used to work or when I'm working now, we have a TEG or ROTEM device. And maybe you know also that new devices are developed currently, just providing a very quick fibrinogen level. So maybe it will be another. But I think it will be interesting to see in the next triennium of maternal death if this device is more used and is used, and if they were different, or if maternal deaths occur in centers who are not equipped with this device.
Yeah, and of course you reported at the end of the study 82% rate of fibrinogen concentrate. So now that device is in place, I'm sure the goal-directed therapy is probably even more efficient. So kudos again. We need to discuss the other papers because we are coming to the end of the hour. We've been given permission to run over a little bit for folks who can stay. So Dr. Bosch, kudos to your national surveillance study, really identifying those cases of high neuraxial block. We've got a few questions from the audience, and I have questions as well. And one of mine actually looks like Dr. Smiley from New York shares, and that is that we're both so surprised that this one patient had a high block as a result of intrathecal administration of 40 milligrams of lidocaine. That seems like a reasonably safe dose. In looking at the case, were there any risk factors or extenuating circumstances? Do you believe the report? Is it possible they gave a bit more? And should we reconsider 40 milligrams as a test dose?
Yeah, I think that's a great question. I agree with Richard Smiles and with you that this is a quite an interesting scenario. I don't think there were a lot of risk factors that would have led us to believe that she had a higher chance of a high block. She had a BMI of 26. She was otherwise healthy. So 40 milligrams of lidocaine, it's a very small dose. If you give it epidurally, you don't expect this. If you give it in the intrathecal space, you also don't expect this. The one thing that could have happened is that it's a subdural catheter that can give profound hypotension and apnea. That's been described in the literature. But even then, 40 milligrams is a very low dose. I agree. And I know there's a lot of discussion on test doses. I think that every dose should be a test dose. So I don't routinely give lidocaine for my labor epidurals.
Stephen Pratt has a paper from Anesthesia Analgesia, probably over a decade old now, so you'd have to dig on it. But he showed that you can use 30 milligrams, and that does cause motor block of the iliopsoas, makes it difficult for folks to lift up their legs, and that might be a bit more specific, a bit more safe. I don't think it really changed practice. I think 40, 45 is a really typical test dose for the folks that are still using lidocaine. Another question, do all planned cesarean deliveries receive single shot spinal anesthesia? Is anybody using epidural anesthesia or combined spinal epidural anesthesia in the Netherlands?
So I think I don't have the data on this. So, but my guess would be that a vast majority of planned cesareans are done under single shot spinal. There are some indications for combined spinal epidural technique. For example, if you expect the cesarean delivery to take a lot longer, or if you have other reasons to believe that you may need an epidural top-up during the procedure. Planned cesareans are definitely not routinely done under only epidural anesthesia. So no, I think most would be done under single shot spinals.
There's lots of questions I'm just reading through. Oh, and I had this question as well. Can you talk about who, you said it's important to monitor these blocks in labor routinely, and the anesthesiologists, of course, are primarily in the OR. So who is doing that surveillance? Is it the midwives, the nurses? How do you train them and make sure that they're doing what they need to be doing?
Yeah, that's a great question. So in our healthcare system, we go to the labor and delivery ward to place an epidural catheter and to start labor analgesia. And as soon as the woman is comfortable and stable, then we hand over care to the treating midwife or gynecologist. So a nurse will be monitoring her block at regular intervals and not the anesthesiologists. And I think that's different in every healthcare system.
And I assume they alert you when there's some breakthrough pain or
They
some
do.
unblocked
They definitely do.
segments and whatnot. Okay, well, Dr. Kuün, I've got a few questions for you. I actually was interested to understand the structure of your training, and a bit of it is explained in your paper. But I'm curious, the anesthesia training is just 2 months? 2 months and we're going to prevent all these or manage all of these emergencies. That just doesn't seem enough, because that's not just OB anesthesia training, that's everything. So is it possible to integrate some of this training into their obstetric months? And how much time are general doctors learning how to be obstetric providers?
So firstly, they are also trained in undergraduate level, but there's also, between the different universities, there's also discrepancies. So some of the universities has a 4-week training program where others only has 2 weeks, and others even, it's about 4 to 7 weeks. Where during the internship, it is only 2 months of the 2-year training program. It is very little. The obstetric block currently is 3 months.
Yeah.
3 months. And no, there is actually not any space that they can actually go over in the obstetric block. That is how the training program was written. It is a big problem, though.
Yeah, and I mean, it's a problem, I think, not just in South Africa. So I really appreciate that the work that you've done. One of our questions in the panel is asking whether this curriculum could potentially be developed and expanded to probably through the WFSA to be available globally for low and middle income countries, for places where we are needing to engage generalist doctors to deliver subspecialty anesthesia care. But that's, I think, a big undertaking. I appreciate your process to narrow down what exactly is the most critical information for this training course. Can you give us any updates of what you've been able to put in place since you did this prioritization exercise?
So there's many stakeholders obviously involved in a process like that. So practically not yet much. There needs to be processes with government, with health systems, with universities, with who's going to pay for the training. Funding is obviously a big problem. Who's going to develop the material, because the university trainers are very short-staffed. So a lot of work to be done, but it's a slow process, unfortunately, although we know where we want to go, but it's going to take some time.
There may be an opportunity for a global collaboration to help expedite that and solve it. It's a huge problem. So thank you for bringing it to our attention. And thank you to all of you for working into the evening to bring this discussion to the global stage. We're so grateful for your publication in the December issue of Anesthesia Analgesia, and thank you to our audience for attending. Have a wonderful afternoon, evening, whatever time it might be.
Thank you very much. Goodbye.
Thank you very much. Bye.